All right. How tired are we? Super. The only person that answers is very, I'm going to assume that's close to average, so I won't dim the lights all the way out. However, we have some pictures to look at here. So. First, we're going to do a little choose your own adventure. A little market research, if you will. I have a question. This is a case, an actual clinical case that we saw here at the Ohio State University. We'll tell you the story of Sugar Bear. Alternatively, if you're like, oh, not a horse case, in case you've seen a lot of things like that, we'd be happy to go over a grab bag of equine x-ray cases. Okay, here's your book. Sugar Bear. Press the button! X-ray cases.
Both.
Here's a, both, we got a both. Okay, here's our happy medium. Let's talk about Sugar Bear first. And if we have some time left, we'll breeze through a little grab bag. How about that? Sound good? Oh, vigorous head nodding. Excellent, I love it. Okay, I lied. One more question for you. And that is this the first time you've been in this room? For whom is this the first time you've been over to the College of Veterinary Medicine? Right? How's it feel?
It's pretty awesome.
It's pretty awesome. How does everyone else feel about that? Does it feel good to sit in here? You want to sit in here? You can sit in here! It is pretty awesome. And I'll just give a little brief plug for this profession. Clearly, I'm pretty sure everybody's here because they're interested in veterinary medicine, but it's a lot of hard work, isn't it? It's hard work already. You're not even in vet school yet. But let me tell you right now, it is worth it. It's worth it. We've been here since 6:30 this morning, and we can have a big smile on our face at the end of a long day like that because this is a cool job. Questions before we start? Stop silence. All right, without further ado, the Sugar Bear. This is not her, but this is very, very similar to what she looked like. Does anyone, so, acknowledging that everyone wants to go into veterinary medicine, who's interested in equine practice? Oh my gosh, way more. So, out of every class of 160 bloody-doo-dah vet students that we have here at the Ohio State University, approximately 10 of them out of 160 go into equine practice. So, this whole room was that's 4 times that rate of people in this room. So, the future's bright. All right, so she is an American quarter horse mare, born in 2006. Anything else we know of that happened in 2006? I don't have an answer to that question off the top of my head. I'm just curious as to what were you all doing in 2006 when Sugar Bear hit the ground?
I was 6.
You were 6? Kindergarten! Kindergarten was an awesome year, wasn't it?
It was. We had naps.
What's that?
We had naps.
We had naps, and come on, all those, those like posters of witty aphorisms that say, all I needed to know I learned in kindergarten. With respect to interpersonal relationships, it's true, isn't it? I mean, you probably didn't learn about like PCR and plant phylogenetics in kindergarten, but you learned how to be nice to people and work in groups and share and have snacks, eat frequently, take naps. 2006 was a good year for a lot of you, and it was a good year for Sugar Bear because she hit the ground and she was born. So she came to see us several years after her birth year. I want to say that 2016 was when this case happened. It wasn't that long ago. She was maybe 10 or 11 years old, and she came to us for evaluation of colic. Who's familiar with that word? What is that? Do you know? Market research. What do you think about that? Oh my gosh. The fact that you're aware that colic is not a disease, is it? It is a clinical sign of a lot of different diseases, and it merely refers to abdominal pain. For example, we had a horse that was transferred to us this morning. Her name is Raven. She's a 15-year-old Tennessee walking horse mare. Are we familiar with this breed? Has anyone ever experienced, had firsthand relationship with a Tennessee walking horse? Are they lovely? Oh, you're not supposed to have favorites, and I say this all the time. Like it's like your children, your patients. You're not supposed to have favorites, but everybody knows Tennessee walking horses are my personal favorite because they are lovely. They're just lovely. They're like a draft horse in a light gray horse body. Just calm, very, very, they're unflappable. And so I have a small child myself, he's 4, which interestingly, horses have an intellect equivalent to that of a 4-year-old human child. You're like, whoa, 4-year-old human children can like be manipulative. Yeah, get out of things. Try not to nap. They'll get over that when they're adults. Or in high school, they sleep all the time. But yeah, horses, do not underestimate the intellect of your equine patients. Have a lot of respect for them. For my 4-year-old child, should he express an interest in horses, he's not going to get a pony. Because his mother doesn't know much, but she knows about ponies. Right? What do we know about ponies? I heard that, and I agree with you. Say it louder.
Assholes.
They have a tendency to be a little on the asshole side of the spectrum. Yes, exactly. Meaning they'll teach your kid to be a really good rider, but they might sustain a like closed head injury in the process. So our kid is going to get a Tennessee walking horse when he's old enough. We had one present to us this morning for colic. Intermittently colicky, meaning down rolling in the mud, right, for the last 5 to 6 days. She ended up having, when we stuck a scope down her stomach, today at about 10 a.m. What were you doing at 10 a.m.?
Class.
Class? What class?
Biochem.
Wait a minute. Question. Does biochem go away once you finish with biochem?
No.
Is there any biochem relevant to the veterinary medicine? A lot of it. We subscribe to the better living through chemistry philosophy, and so that which you might now hate, I don't know how you feel about it, but you will, if not come to love it, you'll come to appreciate it. 2 thumbs up, we do love the biochemistry. It does good things for our patients. For example, this gastroscopy at 10 a.m. this morning on this lovely Tennessee walking horse that presented for colic revealed grade 3+ out of 4 gastric ulcers. So she had some, frankly, bleeding patches in the lining of her stomach, both in the squamous mucosa and in the glandular mucosa, and you will learn more about that when your butts are in the seats here. And I'm very happy that people will be excited about that, because it's cool. Better living through chemistry, we're going to treat that mare with omeprazole, which is like the little purple pill you see advertised on the television, especially if you're awake at 3 in the morning. So, colic, common problem, not common problem.
Common-ish.
Super common, like daily. Whether you practice in general practice or whether you practice in referral practice. If you see horses, colic is going to be your best friend every day of your professional life. Horses are prone to GI misadventure, and we call that job security. Sugar Bear. She came to see us for colic. What does she do for a living? This is what she does for a living. Does anyone recognize that discipline? Wait a minute. What's it that? Yeah, who's right here?
Calf.
Yeah, it's a calf with a rope around its neck. This is calf roping. And Sugar Bear was a very competitive horse, and her owners essentially this was their livelihood, traveling from event to event. They essentially lived in a pole behind, in their horse trailer, a really nice horse trailer, as you might expect, which stayed in the parking lot behind here for several days while Sugar Bear was in the hospital. Her owners sort of lived in our parking lot because that's what they live where their horses are. She was on the road pretty much constantly, and where we became involved, she's originally, loosely housed in North Carolina. Technically, if someone were to ask where she was from, she's from North Carolina, but she didn't spend a lot of time there because she's bombed around the country. And she was at this time in Lima, Ohio for a rodeo. They noted that she had laid down on the trailer while she was being hauled, so they have cameras in the truck so they can see their string while they're in the trailer. She laid down on the trailer, which is ridiculously abnormal for this mare. It's ridiculously abnormal for a lot of horses to do that, but particularly for this mare, she had a reputation for being a bit stoic. And she was unwilling to get up when they stopped to check on her. And when they finally did get her up, she repeatedly, as they're leading her around a rest area, she was persistently wanting to lay down. So it's always kind of a dodgy move to unload your animal that's sick, not in a secure facility, because it's not a sure thing you're going to get them back on the trailer, which turned out to be a bit of an issue here. But long story short, all's well that ends well. The ref vet on call for this competition, who was closed at that time, came to see her and gave her some oral flunixin. Does anyone know what flunixin is? Sort of like the equine Advil. It has a common trade name of flunixin is Banamine. A lot of horses know that term. There's lots of different trade names for flunixin. We always make that, so people often say, we gave 10 cc's of Banamine to a patient here. I'm like, well, if you gave it IV, no you didn't, because we have Flunixiject and we have Prevail, both of which are flunixin, the same concentration. It might be a semantic thing, but this is how you minimize miscommunication between medical professionals. Is say what you mean what you say, use discrete and accurate amounts. So she got 500 milligrams of oral flunixin, PE. What does PE stand for? Anyone know? J class? Physical examination. Very good, very good. PE and rectal. Rectal. What's going on here? This took a turn, didn't it? So what are we referring here? You're like rectal. That's what it says. An abdominal palpation per rectum, meaning we are wearing the horse up to our shoulder, and we are feeling around in their abdomen to try and identify abnormalities in size, position, distension of some of the structures that we can feel. We can feel the caudal 1/3 to 2/3 of the abdomen. If you are a really tall person with a really small patient, you can probably get 2/3. If you are a relatively short patient or person, or just have a short arm, and you're dealing with a large horse, you're going to be very lucky to feel the caudal 1/3 of their abdomen. So acknowledge there's things that you can't feel, but she had a displacement of her colon that was responsible for this bout of colic. If she had an impaction, or like a lot of clients will call it, a compaction, she had a GI impaction that was responsible for this. You're probably able to feel that too. So this is considered an integral part of an examination of a horse for colic. It's baked in the cake. It's assumed that if a horse is colicky, it's going to get a rectal, and it's going to get a nasogastric intubation. Why do you think that is? It seems like cruel and unusual punishment. It kind of is if you ever had it done. So, yes. Okay, exactly, to check the stomach contents. What is that going to tell you specifically, uniquely about horses? This is kind of one of their many Achilles heels. They have a few. They're the most lovely creatures on the planet, especially those Tennessee walking horses. But they have some, factory installed problems. Job security. What do we know about their stomach? They cannot burp or vomit. So if they have something that causes things to back up and their stomach gets really full because ingested isn't flowing downstream, they can rupture their anterior GI tract. And so an important part of a colic exam is getting the tube in there, first of all, seeing if there's evidence of a big full stomach, and it can also be therapeutic in that sense. You can evacuate things and make them more comfortable. But it's also diagnostically useful to know if they have a lot of GI fill in their anterior GI tract anyway. So also an important part of an exam for colic. Whoops. So no nasogastric reflux, that's NGR. If you get anything more than about 2 liters, that's half a gallon, of fluid from the stomach of a light breed horse at one time, that's considered an excessive amount of nasogastric reflux. So if she didn't get any NGR, that's a prerequisite for you putting anything down that tube. So if they hork up a bunch of stuff at you, you aren't going to be like, well, let's give them some oil anyway. There's clear evidence that things are not moving out, so we shouldn't replace, right? But no reflux, so she got 1 gallon.
Mineral oil.
Perfect, mineral oil. What the heck? Why giving this word. That's a lot of mineral oil.
Don't flush things out.
Okay, it's a lubricant, isn't it? And so it does a couple of things. One, it's pretty good at preventing impactions, kind of slides everything through there, but it's also a marker, isn't it? So, clever. If we put this in here, within about 24 hours, we should see some evidence of this oil in greasy oil slick at the south end, right? And if we don't, that's going to be abnormal. That also, I mean, that's not instant gratification as far as diagnostics go, but it's going to be useful information. So it's pretty common. All right. Ugh, crap. Persistently uncomfortable. So that dose of flunixin didn't hold her very long. She got an additional dose of IV flunixin. She got some, up the ante here a little bit, some detomidine intravenously. Does anyone know what detomidine is? It's an alpha-2 agonist. It's often used as a sedative and analgesic. What is an analgesic? What's the term for? Pain relief. Exactly. So this is like you take a couple of Advil. If you have appendicitis, you take 2 Advil, are you still going to feel like you have appendicitis? Probably, exactly. If someone rocked up to you and gave you an alpha-2 agonist, you'd probably be like, oh, that's the stuff, that's better. My appendicitis feels better. Too early until a surgeon yanks it out. She got detomidine, and this is a pretty potent, long-acting alpha-2, still uncomfortable. So ding, 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 we're going to listen to all this. She's throwing up the red flags all over the place, that this is not probably going to be something simple. On a repeat rectal exam, some distension was noted on the right side of her abdomen, and I will give you a little sneak preview as to what lives on the right side that you can tell what it is. It's primarily the cecum and the ascending colon. The origin of the ascending colons are actually on the right side. And so distension on the right is either cecum and or ascending colon. If we do an ultrasound of her abdomen, we can see some of the vessels, the blood vessels that are in the mesentery, or sort of the like suspension tissue of the colon. They're pushed up against her body wall. They don't usually live there. We can see them clear as the nose on my face with ultrasound, and that doesn't diagnose her with a colon displacement, but it's consistent with her colon being in the wrong spot. Push those vessels right up against the body wall. So that's what these look like here. These are those. So there's a mesenteric vein and artery right here, and this is just from rocking up to her with our 3.5 megahertz curvilinear ultrasound probe, hopefully portable, which is cool. Your boss loves you in practice. If they buy you one of those, they love it. With no cords. Just put it on the side of her abdomen. Probably about a hand's breadth ventral to her right paralumbar fossa, and you would see that. So, they said, you're going to need to get her back on this trailer and send her to Ohio State, because this is making us a little nervous here. So, just to give you a little bit of a visual, clearly not drawn to scale. However, from the left side, so here are the dorsal spinous processes of the thoracic vertebrae. Ribs. How many ribs do horses have? Do you know? Same as cattle? No. If you have a photographic memory and very fast at counting, you probably notice there are 18. How many do cattle have? 13! Exactly! Superior species has more ribs. Just kidding. We love cattle. Just kidding. Just gotta throw a little dig into the animal that's the equivalent size. Okay, so from the left, this big horseshoe-shaped folded thing here is the ascending colon that I was talking about earlier. And people talk about it as the colons sometimes, which is kind of a weird turn of phrase, but here's why. The dorsal colon, right dorsal colon is this, diaphragmatic flexure up here, left dorsal colon here, pelvic flexure, left ventral colon, which is lumpy. The ventral colons have haustra. Sternal flexure, right ventral colon is over here, kind of shielded for everything. This whole thing functions as a big unit. It can flop around. This is all free, and really the only thing that keeps it sitting here is the weight of the intestine in the colons. This is what moves around, and people say a horse has a colon volvulus, which is twist, or a displacement, which is not twisted per se, but just gone traveling somewhere. There's a couple of different ways this can move around. The only place this is actually pegged to anything is right over here at the origin, right at the base of the cecum. So this is our public enemy number 1 here, this colon. Factory installed flaw number 72, right here. I'm going to say that with the utmost respect and love. Okay, here's a couple, we're going to skip that. That was a picture of a couple of different types of colon displacement. It's much easier to see in 3D, and when your butts are in the seats at the CVM, you'll learn all about colon displacements with horses. Hopefully that's something you'll look forward to. So when she got here, her temperature was 99.2 degrees Fahrenheit. Her heart rate, pulse, which is a P, was 80 beats per minute. And her respiratory rate, the R in the TPR, was 24 beats per minute. Does anyone see any problem here? Too high temperature? Too high?
Yeah, temperature slightly high.
Heart rate? Respiratory rate. Very good. The heart rate of 80 should catch everyone's attention. If there's something actionable in this TPR, it's this heart rate of 80. What's a normal heart rate for your average adult light breed horse? Hang around, eat some hay, feeling okay about life. Heart rate is? Perfectly average would be 36, which is smack dab, sort of, in the middle of 30 to 40. It's a multiple of, it's an even number, because often people don't actually listen for the whole minute. So yeah, this is way higher than that, and heart rate of 60 is sort of the action point, the flash point for action, if you will, meaning there's something going on here that's probably going to require some more attention. Either they're hypovolemic, they've lost fluid volume, they're in shock, they're very, very painful. In this case, it's probably represented that she was very, very painful. She had already shown some clinical signs of pain that she was overtly colicky, so. Our mucous membranes, we have a surgeon here whose initials are MN, and so she gets the mucous membrane description part of it. Her mucous membranes were cold and tacky, meaning kind of sticky. They should be really, really like slippery, moist, pink like a baby's butt, and not here. When you listen to her abdomen with our stethoscope, horses, they have, so that GI tract, the cecum and the colon, there's 80 to 120 liters worth of capacity in that structure alone, and so there's a lot of fermentative activity so this is sort of the equine equivalent of the rumen in cattle. Cattle and other ruminants are foregut fermenters, horses are hindgut fermenters, along with rabbits, rock hyrax, and a couple other weird things. There should be something, there's a lot to listen to in your average horse abdomen, so hearing nothing should creep you out if you are listening to a horse and evaluating them medically. That's never going to be normal, and most people would give you the same answer. So if you ask 10 people to listen to the same 5 horses, you'll probably get like 72 different descriptions of what people hear, because it's pretty subjective, but nothing is very repeatable, and that's always concerning. She also had muscle fasciculations, this very fine trembling, usually mostly in her flanks, but in her other major muscle groups as well. She was standing very still, but she had this, she was trembling, essentially, during her exam. So we tubed her again, and got no net. She had a decent amount of chunky, dry feed stuff in her stomach, and so you can't necessarily easily see a gastric impaction or stomach impaction well, but this is sometimes indirect evidence of it. We drew some blood from her and did some preliminary sort of stall side or ICU side lab tests. Her hematocrit, or PCV, packed cell volume, was 32%, meaning 32% of her blood, when looked at in a capillary tube, was red cells, and this is a perfectly normal number for an adult horse. Most of them will be in somewhere in the 30s. Race horses, if they're very fit, we've got a 5 or 6 year old standardbred gelding, race gelding, classy guy. He's made like $500,000. He's good at it. His resting heart rate would probably be in the 45 or 48, because he's like Lance Armstrong himself. He's very well trained. His red cell mass has increased as a as a response to that training to increase his oxygen carrying capacity for work. Older horses, babies, will often have lower hematocrit, so in the 20s. Draft horses will often be a little bit lower. But this is perfectly average. Total protein, which PCB and total protein are usually looked at in a pair like that, this is also very normal. If those numbers were, so, I don't know, let's just say her hematocrit was 57%, and her total protein was almost 8, we would say, oh, she's like 10% of the way down the road to being horse jerky. She's a little bit dehydrated, right? That's what happens when you have free water loss. Those two things are concentrated in your blood, so they're often looked at in tandem like that. Also, horses that have more severe or strangulated causes of colic will often have evidence of what we often call hemodynamic compromise. And this is one of the important ways that we detect hemodynamic compromise, is alterations, usually increase in PCB and TP. Lactate is something that you can measure, and we'll use it kind of as a marker of anaerobic metabolism, meaning blood flow is not sufficient to the peripheral organs to support, aerobic metabolism, and so lactate is produced anaerobically and leaches into blood, and we can measure that. So those strangulating things, things that make horses really, really sick, dogs, cats, people, everything, this is kind of a commonality, will often cause an elevated lactate. This is super low. This is actually low enough to the point, like if it was lower than this, the little meter, this is a little handheld meter, would just read low, L-O. So, it's not too exciting. Her sodium, chloride, and magnesium were slightly low, but they weren't considered to be severe. They're pretty mild. So nothing really actionable there, and definitely no electrolyte abnormalities that will explain the trembling, which is always going to be a differential if you have muscle fasciculations or tremor. If you've got some severe electrolyte problems, that can cause it. Not here. So why do we think she was trembling? Pain, right. Gosh, we're making a big case for this horse being uncomfortable, aren't we? So we stuck a needle into her abdomen and collected some fluid. What? Warn clients about that. Many horsemen who've seen the colic exam have seen abdominal centesis, but if you just rock up to their horse and take a T cannula and just cram it up there and don't tell them, it kind of looks like a harpoon, and you may have to explain why you need that sample. So we got some clear straw-colored fluid. That's what the fluid that bathes your intestines should look like. In horses that have those strangulating problems, it often does interesting things like turn orange or red or dark red. This is nice. It's perfect. Total protein is 1, nice and low. Oh, there it is. Low on the lactate. So our rectal exam, we couldn't feel, this is the pelvic flexure again, you mentioned earlier. It's on the left side, so I'm, doing my rectal exam. You use right-handed. You will choose your own hand for this. There's no right or wrong hand. Correct or incorrect, I should say. There's a right hand. But it's not correct or incorrect. People are like, well, I don't want to use my dominant hand because I don't want to get it broken, and I don't want to use my arms broken. Either one. The one I write with or the one I don't write with. And I don't use my right hand to make phone calls while I'm doing the rectal exam. So that's kind of why I use that. Plus, I can't do anything with my left hand. So, the pelvic flexure is down low on the left, and you can usually feel it. It's a common place for impaction, so it's a good idea to check that off the list when you're doing a rectal. But in this horse, we're like, wait a minute. Nobody home. Wait a minute. Like, seriously, nobody home. What the heck? And her cecum, which like I said before is on the right, was displaced axially, means toward the midline. So instead of having to like reach over to the right a little bit to be like, oh, there you are, medial band of the cecum, I'm like, oh, there you are, medial band of the cecum. You're a little further towards midline than usual, suggesting that there's something abaxial to it or away from midline, pushing it that way. She also had some gas-distended colon, palpable on the right. And those vessels that the RDBM had reported, we saw those too, and her colon wall was thick. It should be, on ultrasound, about 4 millimeters in thickness, and so this was twice, suggesting that it might be edematous. She didn't have any effusion, meaning excessive fluid in her abdominal cavity outside of her intestines, and she didn't have any distension of her small intestine, which is good. So now what do you think we should do? This is serious. did. We transferred her to someone else. Well, actually, that is exactly what happened. So she came into our ER crew and she got transferred to us on medicine the next morning because, you know, based on she was reasonably quiet overnight with the help of a little bit of sedation. She'd get colicky and she got a little bit of xylazine, which is the same class of drug as that detomidine we talked about earlier, just a shorter acting variety of it. So if you don't want to really gork them out for a long period of time, you give them some xylazine and see if they see how they respond to it. She laid quietly in lateral recumbency overnight, which by any stretch would not be considered normal, but she was quiet and she wasn't thrashing. And so the owner also was very reluctant to put her on the table and do surgery. And why do you think? She's active, yes. When do you think exactly? So she said this is their livelihood, this is how they make money. So if we do colic surgery on Sugar Bear, when do you think the next time she's going to go to a calf roping competition is? Rehab is at least 90 days. So it's not 2 years, but 3 months she's out of commission. So they're like, oh, if we can just like squeak her through this. That's the reason for the several doses of xylazine here. So she got transferred to us the next morning. And she had the same thing done. So we had a repeat colic exam. This is kind of what happens when cases come to the hospital. If they float around amongst service, we all kind of calibrate our looker. And frequently when you're evaluating these things multiple times, things change, right? Heart rate's now 56. She's been on fluids overnight. So, and she's been getting some analgesics, so her heart rate's come down a little bit. We would call a temperature of 101.5 a fever in an adult horse. So she's not febrile. Respiratory rate's a little high, so maybe she's a little bit, I would still think this is probably pain. Mucus membranes, oh, now they're pink and moist. With the normal, what's that? Crab. Capillary refill time. Meaning, if I take my little finger and squish it on her gums, how long does it take for that little blanched spot to fill back in? And that's a marker of microvascular perfusion. Hers is totally normal. It's good. Borborygmi, which is the fancy medical term for all those herbals and morbals you listen to in the abdomen. Present, that's an improvement. Remember how it was the dead zone in there the day before? But attenuated, so quiet, subjectively. Oh, no muscle fasciculations. So we repeated those same little lab values, very similar to the day before. And we did a little bit more. So we did a CBC and checked her white count, which was a little bit high, but this is consistent with what you'll learn in the future in your professional career as a stress lubricant. So mature neutrophils are a little high, lymphocytes are a little low. It's also consistent, by the way, with her having like her Hox injected the week before as a performance animal. If you give them steroids from the outside, the hemogram looks the same as if they give themselves steroids from the inside, which is part of the stress lubricant. So, anyways, nothing terribly exciting there. So we tubed her again, got 4 liters of net reflux, a little bit more. It wasn't stinky, bilious, suggesting that, so horses, they secrete gastric acid all the time. And this is very much different to you or I or a dog or a cat, which usually only secrete gastric acid in response to a couple of different stimuli. Feed the GI tract, thinking about food, that's the old cephalic phase. If you're thinking about food and you start to drool a little bit, you can assume that your stomach is churning out a little HCl. Horses, it doesn't matter if they're fed or fasted, whether they're thinking about food or thinking about whatever it is they think about, they're secreting gastric acid all the time, which is why meal feeding horses, giving them a big, 4 to 5 pounds of sweet feed twice a day, is not a good idea, because in that interprandial period when they're eating nothing, their stomach is still churning out acid. It's kind of the same thing with bile. They're constitutive biliary secretors as well. This is because of 2 little quirks of anatomy. You will have a heads up on the rest of your vet school classmates if you can remember that horses do not have a gallbladder. They don't have one. Not factory installed. And they also don't have what's called a sphincter of Oddi, which is a little sphincter right before the common bile duct dumps into the small intestine. So it's like, a highway, free for it's like the autobahn of bile. It just flows right down from where it's produced into the small intestine constitutively. So, if you've got an empty stomach and you stick a tube into it and start a siphon, you might very well pull off some of that fluid if the stomach is empty. Bilious fluid just probably suggests that the stomach is empty because some of that bile is going back in. Okay, so we've got this horse that is just maybe a little bit better, but not quite right. She has some things that actually seem to have progressed. She's producing more reflux. She is insured. Major medical insurance, your average garden variety major medical policy for a horse will pay for $7,500 of whatever it is you're going to do, which is usually enough to make a huge dent in your average garden variety colic surgery bill. Although those sick ones we talked about that have strangulating things, a lot of times those leave our hospital with like $10,000 or $12,000 bills. So it's not going to pay for all of it, but it'll pay for a lot of it. So she's insured, and they love her. She's good. They will invest in her. They were just a little hesitant because, oh God, many days. But anyways, she can have whatever she wants, although now she can't have any food because she's been colicky, and we withhold feed from them until the situation proves itself. So, we took some x-rays of her abdomen. And you might be like, what? In a horse? Like a big one? You'll see in a second what kind of things you can see on abdominal rads in a horse. But what do you think we're looking for? In general, this is very different to small animals or to people. They don't do abdominal radiographs in people very much anymore. They usually do what? CT. In a horse, you're looking for something mineral. So an enterolith, a rock, sand, big accumulation of sand in the colon, or a fetal skeleton. And we don't use abdominal radiographs to diagnose pregnancy in bears, so this is sort of like a gee whiz. Basically looking for two things. And I'll show you why. I'm going to make it really dark, or fall asleep, or go ahead and fall asleep, it's okay. Sleep is usually at a premium in most people's lives. And sleep, as I say to my small child, sleep is healthy food for your brain, isn't it? It is. Brains don't work when they're sleep deprived. Well, so those three things that we'd be looking for, do you think any of those might be associated with signs of colic in adult horses? Which ones? You're like, even the fetus? Yes! Even the fetus! Okay, here we go. Oh my God, good Lord, what is all this stuff? Okay, let's start. So, even with a big radiograph plate, 14 by 17 inch plate, this is about as much of the abdomen as we can get. We need at least 5 to 6 views to get the whole abdomen of an adult livery horse sort of wallpapered up in front of us. So we have to do a little patchwork quilt action here. This is cranial. Here's the sternum. Here's part of the riblets. This is called the costochondral arch, right here, costochondral junction. This is lung. What's this guy? Separates the abdomen from the thorax. That's the diaphragm, exactly. Does anyone know what cut of meat diaphragm is, by the way? And what, huh? Ooh, I think it's hanger. Someone told me it was hanger steak. You can't find hanger steak very often because it's very good, it's very tender. Took a turn there, we didn't eat this. She was all full of drugs, we wouldn't be able to eat her anyway. Okay, so here, that colon we were talking about, this is what it looks like radiographically. This is all ingesta, feed material, crammed in there. So there's really not a lot to see here in the way of abnormalities. Remember, we're looking for those three very specific things. Things of mineral density. This, by the way, is what mineral density will look like. This is her own skeleton. If we move towards the back end a little bit, so we lose the sternum, we still have some ribs here. This is more colon, and this is, you can't say what that is. Adult horses are so big that you can't get the detail that you can in small animals, so this is why we're sort of going into using this to look for mineral densities. This is the fold of her flank here. This is again her abdominal ventrum, abdominal belly. So if we move dorsally, here's the diaphragm again. This black triangle up here is lung. And you might see you can't see a lot of detail up here because it's burned, it's essentially burned out. This is technique to try and get enough juice to shoot through the abdomen, which is wider, and doesn't contain as much air as the thorax does. So there's more stuff to attenuate x-rays in this abdomen. So the technique that's chosen for this study is to optimize abdominal imaging, and it is crappy for the thorax. But we get a little thorax for free, so we'll with digital radiology we can kind of adjust that, isn't it? This is a fluid line right here, probably in her colon. This is sort of some little wads and blobs of small intestine up here. There's nothing terribly abnormal to that. Again, more fluid, small intestine. I don't see any abnormal mineral densities here. Same thing. This is colon. You remember those lumps I said that ventral colons had? This is kind of what those look like radiographically. These are called haustre, lumps like that. So this is large colon. There might be a little bit more gas in there than we would expect. We wouldn't use radiography to tell us that, though. We would use our arm. And this is probably that thing. Remember I said there's something pushing her cecum axially? This is probably gas in her ascending colon, and oh my gosh, there it is again. A little external corroboration is nice. You see anything here? So yeses, what do you see? Can you describe the abnormal structure? There's that gassy colon again. I mean, yeah, maybe. Hold on. What's this? Like racquetball-sized, perfectly spherical mineral opacity sitting in her mid-caudal abdomen. Whoa, that's not right. I don't see it there. Oh, it's like the full moon rising right there in the middle of her abdomen. We were like, slap her on the ass and send her to surgery. She's got an enterolith in there. So guess what? She went to surgery because we're like, well, she has an enterolith, and there it is. Let's find our surgeon friends and them and take it out. So this is very similar to what most colic surgeries will look like here at OSU. So usually what happens is if we in medicine send a case to surgery, very often we'll, especially if the clients are here, living in our parking lot, as surveyors were, we'll stay outside and kind of run interference and be like, what are you guys seeing in there? Okay, let's go out and talk to the owner. So we get a phone call from the surgeon, actually from the technician holding the phone up to the surgeon while she's all scrubbed in. Intra-op, which is always kind of a weird thing, and she said, does this mare have a marble? What does that mean? Some weird horse vernacular slang. Is anyone familiar with mare marbles? Okay. People will sometimes use the shooter marble, like the big one, from like when people back in the Stone Age when we used to play marbles. I mean, back in the good old days. The big marble is a shooter, and for a period of time, equine vets sort of co-opted this big marble, sterilized it, stuffed it in the uterus of performance horse mares to keep them out of heat. So it sort of was like a little kind of like an IUD, if you will. They didn't work really well. You had to sort of put them in there when they were in heat and their cervix was open, and very often what would happen is, before their cervix would close down, then they would just fall right back out again. And they have this really nasty habit, the glass, of breaking, shattering into lots of little shards. And you can imagine how lovely that is to have shards of glass in your uterus. So usually if people are trying to do this for behavioral reasons, you can imagine what happens to the behavior. Besides the humane concerns, the behavior doesn't improve with shards of glass in the uterus. So this has sort of gone out of favor, but there's occasionally still mares rocking around with these things in. So I was like, I don't know if she has a marble. I'll check. Hello, owner. So the owner said, what? So I turned and I asked this guy, I was like, does she have a marble? Do you have a marble? And he's like, no. And he's like, I thought that fell out 2 years ago. It had been in there for the better part of 3 years. And usually the half-life of those things is people are lucky if they'll stay in for a year and a half when people used to use them more. He didn't actually think it was still in there. So he was like, dang on, there it is. So she did indeed, and usually the uterus is one of the tissues that's usually I mean, people will give a cursory feel of the uterus if they can reach it, because the uterus and the ovaries are pretty dorsal. And if this horse is on her back, like surgeon friend MM has to put on like a snorkel to get down there. So usually, most people are not scanning doing a really thorough evaluation of the uterus and ovaries, unless it's a pregnant mare, there's some other reason to expect that that's a problem. But sure enough, reaching down in there, could feel that this thing that was visible on her x-rays was indeed a uterine marble, freely movable within her uterus, located at the tip of the left uterine horn, and visible on those ab rads. So, in retrospect, looking back at those rads, that's a pretty small enterolith, but that's exactly what they look like radiographically. They're usually spherical. If they're single, radiopacities somewhere in the mid-abdomen. If that marble was in her GI tract, in the places where they usually form, they could usually pass it on. And enteroliths are a problem because they essentially function kind of like a ball valve, and they get crammed into a smaller caliber piece of the GI tract. They get stuck, and it causes an obstruction, and hence a colicky horse. Oh, there it is. Big old marble in the uterus. So, at the same time, she also did have a cause for her colic. She had a right dorsal displacement of her colon. Cecal vessels, distended colon, on radiographs and on our rectal exam. So they fixed that at surgery. No enterotomy, meaning sometimes they'll go ahead and they'll make a hole in the colon and dump all the poop and all the gas out of it, empty it all out, to make it easier to reposition things and to minimize the risk of some kinds of postoperative complications. And she recovered like an angel. It was fantastic. So once she recovered and she spent the night in the ICU, we had our reproductive service look at her. And the owner was very surprised and actually was a little bit anxious that it was still in there, because at this time, the stories of fractured marbles were starting to appear in the literature, and he was like, oh God, what have I done? We gotta get that thing out of there. And he's like, can you still get it out of there? And so Therio went to look at her with the goal of actually trying to milk this thing out, get it out of there. And she had a closed cervix. She was in diestrus, not in heat. And so, she was given some Dynafrost to bring her into heat, relax her cervix, and make it so that she could have that thing milked out. And it was ultimately removed manually. And there it is. Can you imagine? 3 years with this little foreign body. So, the owners were like, okay, she seems good to go, we're out of here. So they went back on the road with the rest of their string, left her, and so she stayed. This was actually like, 40 days, something like that. She stayed with us for a while. She did great post-op, and she's still, as of about 6 months ago, doing fantastic. She's actively competing after her stay at the OSU colic camp. So that was kind of an interesting case because it started out pretty garden variety and then has a little wrinkle. And that is another reason why veterinary medicine is a very cool job, because that happens on a daily basis. It's never the same day twice. Different day, different sugar. Questions? Comments? Yes.
How do how do they form in the stomach? Is that diet related?
So the question is, those enteroliths we're talking about, I'm going to see if there's e-foam on this. I'm going to, you guys have a club email paycheck? I'm going to send you some radiographs, some examples of enteroliths from patients, so you can see what they look like. They look very similar to this, they're just a lot bigger. They form, so typically the chemical composition of them is usually a combination of calcium, magnesium, and phosphate in some configuration. There's some biochemistry, but there's actual physical chemistry in there. They are diet related, but it's not a linear relationship between, if I feed X, my horse is going to get an enterolith, and they take years to form. So enterolithiasis isn't something we see in young horses. So if you have a 2 or 3 year old, it's probably not going to have a big rock in its transverse colon. Usually those are middle-aged to older horses that have had time to cook some of those, and they can have multiple. So if you're ever doing colic surgery on a horse and you pull out an enterolith that has a flat side, meaning it's been up against something else hard, there's more in there. You gotta find these little enterolithitis, and some horses will have dozens of them. They form because of diet, but what components of the diet put horses at risk are not entirely clear, at least as far as how to prevent them. Horses on the West Coast get them more often. Arabians are thought to be predisposed, but on the West Coast there's also a lot more Arabians around than in other areas of the country, so it's not clear whether that's really a breed predisposition. And legume forages like alfalfa, clover, those are, they're higher in calcium and magnesium, and so a management strategy that people will apply is to try and avoid feeding legume forages in horses that are thought to be predisposed. Sometimes they'll give them apple cider vinegar. There's literally no evidence that that prevents anything, but that's something that you probably encounter. It's one of the, when people are grasping at straws for a reason to not have this happen again, those are all kinds of stuff. It's not a problem that happens commonly enough that you can get lots and lots of cases together to do like a clinical trial with therapy. Cutting them out fixes the problem. So prevention is a little bit dodgier, but this is kind of an expensive thing to deal with. But, good question.
Using mineral oil, I know that there's some other options like Epsom salt. How can I found that Epsom salt will break down the infection very quickly actually, but mineral oil is beneficial for telling that it's fast. Is there a way that you can do both?
Oh, absolutely. If you have some free time, you should Google something called surgeon in a bucket. So, Epsom salt, DSS, mag sulfate, water, and a couple of other things in a bucket, pumped in through an NG tube. So, mineral oil is a lubricant. It doesn't help break up anything. What happens is, like, if you take some fecal balls, a little experiment, science fair, if you will. If you take that mineral oil and you throw some horse apples in it, you can come back several hours later. They will be slimy on the outside, but they will be relatively intact. If you take some Epsom salt, which is magnesium sulfate, or sodium sulfate, people will give either of those things for the same reason. Put a gram per kilo in 4 to 6 liters of water and dump those horse apples in there and come back. It will probably fall apart when you try and pull it out. So as an osmotic or drawing agent, which is what mag sulfate and sodium sulfate are, they sort of pull fluid into the intestine and hydrate the contents. So mineral oil doesn't hydrate impaction, true. And that's why it is much better at preventing impactions than it is at treating an established one, although you're not going to harm an established impaction by giving some mineral oil. Those osmotic cathartics, mag sulfate, sodium sulfate, are better for breaking it up, as well as enteral fluid therapy, or fluid therapy given into the GI tract, as opposed to giving an IV. Good question. Usually both. Jokes. Anyone have any jokes? Always circling around for new jokes. Dad jokes. Isn't that a thing? Someone tells a really good one like 2 weeks ago. I promptly forgot it. Let me start writing this stuff down. That was good. I can use the seat where the person was sitting. Which one was so damn good. Well, it was good to see you all. I'm excited for you guys to come back. And if you would like to come visit us at some point,